Chapter 32, Immunologic Disorders. We learned about the function of the white blood cell in the previous chapter and the role of the white blood cell in the immune system. So now we will talk about the disorders of the white blood cell. Number one is your neutropenia. This occurs when the total number of the neutrophils is abnormally low. Neutrophils is one type of the white blood cell. So if there's an abnormally low level of white blood cell or this neutrophil, the patient will have risk or increased risk for infection. Those common sites of the infection are your lungs, blood, skin, urinary tract, the GI tract, sometimes even the esophagus. Patient will have esophagitis and perirectal area. What are the common causes of neutropenia? Some of them would be the decreased bone marrow production, because remember, the white blood cell is being produced in the bone marrow. So if there actually is an alteration with the function of the bone marrow, then it could actually cause neutropenia or the decreased bone marrow production. And what could be causes of this decreased bone marrow production? Chemotherapy is a big thing. Radiation also is a big thing with that could be causing decreased bone marrow production. Some drugs can actually cause this, and some autoimmune disease or autoimmune reaction can also cause decreased bone marrow production. And then some treatment that we can give for the neutropenia. Again, the patient will be at risk for infection. So we can give them some treatment. We can give them antibiotics if there's an infection that's present, especially if it's caused by bacteria. We can give them antibiotics, and then we will put them on what we call neutropenic isolation or neutropenic precautions. The difference between like the regular isolation that we do, like contact isolation or droplet isolation, is that the caregivers or the nurses or the staff are the ones that's actually wearing the PPE before they will even go in the room and expose themselves to the patient. With neutropenic precautions, we're trying to make sure that we're preventing further infection, or we're even preventing infection to the patient. So the patient, when they go out of the room, then we make sure that the certain precautions are actually being exercised, because they are compromised. They're gonna wear mask. They're the ones that's gonna wear mask whenever there's going to be an exposure to other people. Also, in addition to that, like plants, right? You don't want to expose patients to like flowers, for example, that could cause the bacteria or any other parasites or fungi or virus, any pathogen can actually increase the risk of infecting the host, the patient. Non-Hodgkin lymphomas. We'll talk about those two types of the lymphoma, the non-Hodgkin lymphoma and the Hodgkin lymphoma. The difference between the two is the affected cell. So we'll talk about that Reed Sternberg cell later on when we talk about Hodgkin lymphoma. But for the meantime, let's focus on non-Hodgkin lymphoma, which is the NHLS. This is a group of cancer of the lymphatic system that could actually spread to other organs. When we did go over the lymphatic system, even that picture that I showed you in the previous chapter, the lymphatic system is actually like a channel of that system that is actually all over the body. So if you have non-Hodgkin lymphoma, this is actually one of those cancers that could easily spread to other organs because it has something to do with the lymphatic system. Okay, there's the stages for non-Hodgkin lymphomas. You have a low grade, intermediate grade, and high grade. And the higher the grade of the lymphoma, the more aggressive the cancer is. Treatment. How do we do treatment for non-Hodgkin lymphoma? We can do immunotherapy. Immunotherapy is helping the immune system, altering or changing the immune system. Let's say we're going to boost that immune system so that it could actually help with treating the disorder. Radiation also, or chemotherapy, is to kind of like destroy those cancerous cells depending on the stage of the disorder. Survival rate depends on the grade at diagnosis. Obviously, the more advanced we catch it, then the less or the higher of the poor prognosis is, right? And the earlier that we catch it, then there will be a better prognosis. Hodgkin lymphoma, again, like we said, the difference is the type of the cell that is affected in the lymphatic system. So for your Hodgkin, this is a type of lymphoma that is characterized by what we call Reed-Sternberg cells in the lymph nodes. And I'll show you guys in a little bit. It looks like owl eyes. We call it owl eyes even because it does look like it. Incidents are high in the 20s and in the 50s and more common in men. How do we treat this? Again, we can do radiation and chemotherapy, and we can even do surgery. One thing to remember about Hodgkin lymphoma is the treatment sometimes have those what we call late effects of treatment. Right here. So it could be months to years after the treatment for the Hodgkin lymphoma. And among those late effects are could be cancers, like more cancers or a different cancer, various cancers, or infections, infertility, and the hypogonadism, which is the decreased function of the sex organs or the gonads. Here's your Reed-Sternberg cells. See how I told you guys that it kind of looked like owl eyes, like eyes of an owl, right? This is what we call Reed-Sternberg. And this is the cell that we see for Hodgkin lymphoma. Then we have leukemia, which is the cancer of the white blood cell in which the bone marrow produces too many white blood cells. So the bone marrow actually is producing a lot. Okay, there's an abundance of white blood cell. But remember the word immature. Okay, immature white blood cell. And it means that that white blood cell is not able to function normally because it's an immature white blood cell. It's not functioning like the normal or regular white blood cell. So what could be causing this disorder? It could be exposure to large doses of radiation or certain chemicals. One example is the benzene that we found in gasoline. Okay, and then you have the types of leukemia. You have myelogenous leukemia and lymphocytic leukemia, where there's also under this myelogenous and lymphocytics, there's what we call chronic or acute. So for example, the patient has a myelogenous leukemia and it's actually chronic, so we call it chronic myelogenous leukemia. And then, for example, your patient has a lymphocytic type of leukemia and it's chronic, so you will call it CLL or chronic lymphocytic leukemia. just to like show you how we call those types of leukemia. And same thing as your acute. So you will have acute myelogenous leukemia or acute lymphocytic leukemia. From the name itself, acute is always those um, sudden, right? It appears suddenly, while the chronic leukemia, it takes some time, even months or even years, for the white blood cell to actually go up. But again, please remember, we do want an increased white blood cell, but not immature white blood cell. Okay, so treatment, one of the treatment is what we call imatinib mesylate, or other name is your Gleevec. It's a protein tyrosine kinase inhibitor that targets those leukemic cells while sparing normal cells. It's a good medication. It's an oral taken once a day, and there's only minimal side effects that have been reported. So there's really a good prognosis or good outcome from using this medication. Okay, signs and symptoms would be infections because of those immature white blood cells, and then low red blood cells. What's happening is that in the bone marrow, example, this is your bone marrow, the spongy center of the long bones. In there, it's crowding because of too much white blood cells. So for example, the yellow is the white blood cell, right? Because there's a lot of white blood cell, what's happening is it's like crowding. It's like crowding those other cells that's in there. So one is your RBC. So let's say the green ones are your RBC. So if there's not much enough space, so result would be you will have a low red blood cell because of those too much immature white blood cell that is actually crowding the bone marrow. Okay, then we have fatigue, paleness, the tachycardia, tachypnea. Again, you have a low RBC, right? So your body is actually trying to compensate because of that low RBC, that low oxygen. You will even have low platelets because again, it's crowding up in there in the bone marrow. Gingival bleeding because of this low platelet. So if you have low platelet, chances are your patient is going to have some kind of bleeding or at risk for bleeding. Melena is actually a dark stool, right? Dark stool. And then epistaxis obviously is the nose bleeding. All right, diagnosis. So we also would order some blood draw for the patient. You have your CBC, because what you will see in the CBC is your white blood cell. So if you have an abnormally high white blood cell, in addition to your signs and symptoms right here, then they will diagnose the patient with leukemia. And then we will have treatment, which is high doses of chemo, because what they're doing is actually they want to kind of like destroy the bone marrow, destroy the bone marrow, okay? And what they want is to actually for that destroyed bone marrow to kind of like regrow, okay? And hopefully when they regrow, it's not producing too many immature white blood cells. Because of the risk for infection, we can also give the patient antibiotic. Blood transfusion if needed, because you will have low red blood cells, low platelets, so we will have to replace those cells. And then stem cell therapy also is believed to help with the leukemia. Going back to the anatomy and physiology, remember that stem cell is actually capable of becoming those cells like your white blood cells and their RBCs or even platelets later on. Other immune system disorders, one of them is the hypersensitivity reactions. This is, or what we call it, allergies, is the exaggerated response of the immune system to something that's actually the body is registering it as pathogen. And then you have the autoimmune diseases, which is idiopathic thrombocytopenic purpura or the thrombotic thrombocytopenia purpura. Hypersensitivity reactions, or what we call allergies, is again the exaggerated immune response. It could be uncomfortable and even potentially harmful. Signs and symptoms would be that bronchioles would be constricted. You're gonna have a bronchial constriction, okay? There will be peripheral vasodilation. That's why swelling is actually one of the symptoms or signs that you will see. And there will be an increased capillary permeability. Again, that's why you will see those swelling. You will have those runny nose or increased vascularity in the nose. So you will see all those symptoms of allergy. Treatment, what do we give is the epinephrine, right? And or antihistamine, because again, histamine is the one that gets released when you have an allergic reaction. Okay, what it does is that it vasodilates, so gonna give them antihistamine to kind of like block that effect of the histamine in the body. And then we can give the patient steroids and hemodynamic support. Idiopathic thrombocytopenic purpura is when the immunoglobulin G mistakenly helps to destroy the patient's own platelets. That's why it's called thrombocytopenic purpura. Okay, here, let me highlight it. Um, the immunoglobulin IgG is actually mistakenly helps to destroy the patient's own platelets. Okay, what could be causing this idiopathic thrombocytopenic purpura? Some drugs, some medication can actually cause this. One of them is sulfonamides, which is an antibiotic, thiazide diuretics, chloropropamide, quinidine, okay, and gold. Um, and then HIV infections is at high risk for this because again, HIV is actually decreasing the immune system of the patient. So they're at high risk for developing this idiopathic thrombocytopenic purpura. How do we treat this? We can give steroids, we can give that IV immunoglobulin, and then if it gets really, really bad, that the patient's own immune system is actually attacking the body, then we can actually remove the spleen, right? Removing the storehouse of those white blood cells. And then to increase circulating blood vessels, immunosuppressive therapy, and drugs that can increase platelet production. Drugs that can increase platelet production. All right. Thrombotic thrombocytopenia purpura. This one is characterized by extensive formation of those blood clot and decreased blood flow to the affected tissue. So signs and symptoms, you will have renal impairment, you will have neurologic symptoms because of this, fever, because this is some type of inflammation or some thing that's going on in the body that needs to be corrected, thrombocytopenia, and hemolytic anemia could be signs and symptoms. All right, and causes would be it could be inherited, or it could be acquired. Okay. Triggers, there will always be trigger. One of them is pregnancy, HIV, lupus, surgery. So this four right here, if you see the commonality of them, is that their immune system is actually low, right? Stem cell transplant too, okay? And then those drugs like your ticlopidine, Plavix, your clopidogrel, chemotherapy, hormone therapy, and quinine can actually cause your thrombotic thrombocytopenic purpura. Hormone therapy, if you guys recall, whenever we have a patient that is on birth control, for example, that's a hormone therapy. They are actually at high risk for blood clot formation, right? Okay, so how do we treat this? There's what we call plasmapheresis. Plasmapheresis is when we actually remove the immunologic agent from the plasma or the blood of the patient. So we remove the blood, a patient's blood, and then it will be centrifuge or kind of like being filtered in a machine. And then what it does is it actually separates the blood components so that the plasma is the one that we can selectively remove. And then after it gets centrifuged, the patient's own blood cells, the white blood cells and the red blood cells and the platelets are being reinfused during the treatment or put back to the patient. Other treatments, some treatments are your steroids, your vincristine, rituximab, cyclosporine, and we can even remove the spleen or do a splenectomy. Systemic lupus erythematosus is an autoimmune disease in which the person's immune system loses its ability to recognize itself and attack its own immune system. The causes are unknown, but it's believed to be genetics, and there will be triggers for the exacerbation of the SLE. There are four types of systemic lupus erythematosus. They are systemic, cutaneous, drug-induced, and neonatal. Systemic is when there's like a um, multi-organ inflammation. So there's like multiple organs that are being affected. Cutaneous is when it's the skin that is being affected, and then we have the drug-induced when some of the drugs are actually causing this autoimmune disease. And then neonatal is, of course, from when the newborn is actually having this disease, because what happens is that the newborn receives the antibodies from the mother. So, what are the signs and symptoms of systemic lupus erythematosus? So, damage to organs, like I said, is multi-organ inflammation or damage. A lot of the organs are being affected: your skin, the joints, kidneys, central nervous system, cardiovascular, the membranes lining the body cavities, hematologic, and immune system. And eventually, if it's not corrected, it might lead to organ failure. This is more common in women, especially in childbearing age, and also common in African Americans, Latinos, Asian Americans, and then there will be remission state and exacerbation state. So there's no cure for this disorder, but what we do is we do symptom-based management, and the goal is to prevent the exacerbation of the disorder. Once the patient reach that remission state, that's your goal, is to actually keep them in the remission state. Uh, Diagnosis that we do is we do some blood tests and see if the immune system is actually working properly for the patient, and then also constellation of the symptoms that we will talk about in a little bit. But if you see in the question that you have that the patient is actually having those butterfly shaped rash across the bridge of the nose and the cheeks, then that is actually one of the keyword for systemic lupus erythematosus. Other signs and symptoms are your discoid rash or those red scaly patches, photosensitivity, oral ulcers, arthritis, pleuritis or pericarditis, kidney problems like urinary disorder, neurologic disorder because your central nervous system is affected, hematologic disorder, immunologic disorder, and then, like I said, that we will do some blood tests to diagnose the disorder. So you will have, the patient will have a positive ANA test. This test is testing for like an antibody, and if that is present, then that is an indicator of a systemic lupus erythematosus. The American Rheumatism Association has established criteria for SLE. So to diagnose SLE, the patient will experience any four of the following that we did talk about, your signs and symptoms, plus the positive ANA test. Human immunodeficiency virus, or HIV, is the virus that is causing the disease called AIDS, or acquired immunodeficiency syndrome. And it's very important to distinguish between the two, because sometimes, it's very easy to be confused between what is HIV and what is AIDS. So HIV is the virus that is causing the disease. The disease is AIDS, the acquired immunodeficiency syndrome. And we'll talk about the history, pathophysiology, stages, signs and symptoms, complications, diagnosis, and treatment. History of this virus. It started appearing around 1940s, but it was not until 1980s when this new pathogen were actually recognized. What was happening was that young men were starting to get sick with these signs and symptoms like oral candidiasis. They were having herpes, pneumocystis, jirovecii, pneumonia, Kaposi sarcoma. And these are not just, you know, young men like the all the young men. It's actually those young men that's having sex with another man. It was actually more common in the demographics, the 25 to 29 years of young men, gay or bisexual, and then it was also common with of African Americans, Caucasians, Hispanics, Latinos, Native Hawaiian, and other specific islanders. Gender, males accounts for 81% of the cases. And then later on, it actually was affecting other populations too, including the following, like individuals with hemophilia who must use blood products to treat the blood clotting disorders, patients who received a transfusion with the HIV infected blood or blood products, newborns and breastfed infants of HIV infected mothers, and then injection of the drug users and partners, including heterosexuals who had unprotected sex with those infected with the virus. Mode of transmission: body fluids. like male to male sexual contact, male to female sexual contact, mother to child, like I mentioned earlier on, injection of the drug use, and then those blood transfusions. Okay, pathophysiology. What is this virus doing to the body? So we did talk about the T4 cells, which is also called the CD4 cells. What this virus does is, for example, this is your CD4 cells or T4. This virus actually will attach itself. This is your virus now, and it's attaching itself. And what it does is it infuses its own genetic material into the host's DNA. And what it does is it eventually it will destroy the T4 helper cells or the CD4 cells when it infuses the genetic material. So going back to immune system, your T4 helper cells or the CD4 cells is actually important when we're trying to combat infections. So if the HIV virus is actually destroying the CD4 cells, what happens is that the immune system of that patient that is infected will drastically go down, and the risk for infection will go really high. Okay, viral load is a term that we use to describe how much of this virus is found in the blood. So it means the higher the viral load is, then it means that the virus is actually everywhere in the body, right? The higher the viral load is, the higher of the number of the virus is in the blood. HIV testing, this one is actually checking the presence of antibodies against this virus. And it actually is detectable 12 weeks after the infection, from infection. So it means the person might be infected today and they go for HIV testing, they're going to be negative. It's not going to be able to read that viral load yet, okay? Because it takes 12 weeks from the infection, from the day that they got infected, before that HIV testing can actually read the antibodies in the body of the patient. So stages of HIV, you have initial, latent, and third stage when there's like opportunistic infections already. The initial stage is 4 to 8 weeks. 4 to 8 weeks. And there will be high levels of this virus in the blood. Viral load will start to go high. In latent stage, this will be 2 to 12 years. This is when the CD4 actually starts to decline. Your third stage is when there's going to be some opportunistic infections, and we'll go over that in a little bit. And the HIV is now going to be called AIDS, or the disease AIDS, when your CD4 level is now less than 500 cells per cubic millimeter. Okay, so that's your number that you need to remember. Is when the CD4 level actually go down to 500, then that becomes what we call AIDS. Okay, medications that we give is what we call HAART, or highly active antiretroviral therapy, or HAART. This is a combination of drugs, multi-drug regimens. And what they do is they actually make sure that that viral load is going down to the point where the patient body is actually having that some kind of immune system to kind of like fight off some infections and the preventing the opportunistic infections. So what are signs and symptoms? There will be generalized flu-like symptoms such as your malaise, nausea and vomiting. There will be decreased appetite, rash and diarrhea, fatigue, and weight loss. Then there will be frequent and persistent infections because this is the immune system that is actually being affected. So if your immune system is low, then you will have persistent infections. Fever, night sweats, swollen lymph nodes, and other signs and symptoms of the infections. Okay, let's go over this figure 32.1, clinical symptoms of your AIDS, acquired immunodeficiency syndrome. You see those three pictures. Letter A is when there's going to be a severe weight loss and anorexia. Letter B is your Kaposi sarcoma. Those are the lesions in the skin, and you will see it right there in the chest. And C is perianal vesicular and ulcerative lesions of herpes simplex infection. All right, and then 580, that figure 32.2, are those tissues that can be infected by the HIV. So you have the brain, the macrophage, the brain glial cells, lymph nodes, thymus gland, bone marrow, skin, lungs, colon, duodenum, and rectum, and then your lymphocytes in the blood, semen, and vaginal fluid. Opportunistic infections, like we said, are those complications from this virus, the HIV. It's either parasitic, if it's caused by parasite, fungal, if it's caused by fungi, viral, if it's caused by virus, bacterial, and oncologic. So look at that table 32.2 in page 581. Highlight that and then read through it. Make sure that you know those infections. What are their manifestations? What is the mode of transmission, and how can we prevent it? Okay. Kaposi sarcoma, common type of neoplasm that develops in people with AIDS. This is caused by associated herpes virus that is transmitted by exchange of saliva. There is no cure. The goal is long-term remission, or we can give antiretroviral drugs, chemotherapy, and doxorubicin, daunorubicin, and paclitaxel. Or we could do some surgical interventions, cryotherapy, and radiotherapy. Lymphoma, your Hodgkin and your non-Hodgkin. These are cancer that originates in the lymphoid tissue. Could be a complication of HIV. The patient will have fever for more than 2 weeks. Again, there's no treatment. There's no cure. The goal is to reduce the viral load. Also, medications that we use is in 585. So read through that, make sure that you highlight them, and try to remember the use and action of each medication, side effects, and nursing intervention, very important for you to know. 586 is the side effects of this antiretroviral therapy. And then again, like we said, there is no cure to this disorder or disease, but we have to emphasize prevention. Emphasize prevention. Remember what was the mode of transmission for this virus. So, educate your patient. It's the exchange of bodily fluids, so make sure that's part of the education, okay? Nursing care of the patient with HIV, in effective management of the therapeutic regimen, because if you recall, we were talking about that HAART multi-drug regimen. It's like a combination of medication. So there's a lot of medicine that this patient is going to take. Most of the time, patient will feel a little good and then they will stop taking their medicine. Anxiety, of course, they will have all these signs and symptoms, and they have this virus, and then they know the complications that could happen to them. So they will be under, they will have anxiety. Potential for infection is a big thing for HIV. Like I said, it's because the immune system is down, so there's a high risk for infection. Impaired oral tissue integrity because of the ulceration in the mouth, inadequate nutrition, fluid volume deficit, confusion if it's actually the brain cells that is now being affected, pain because of all those complications that we did talk about, like those herpes and the Kaposi sarcoma. Those will be painful. Make sure we're doing pain control. And inadequate coping. Maybe we can refer to social service, psychotherapy, and those people that could actually help with um, emotions and mental health of the patient. And that is the summary of chapter 32.